Welcome to the second half of the sleep measurement lecture. Now we're going to talk about the typical sleep studies that are done in the sleep laboratory. Of course, actigraphy is often done, as we were talking about before. This is especially done for circadian rhythm disorder, when you want to verify that people are indeed going to sleep, for example, at 3 in the morning and sleeping until noon, and need to make adjustments to their sleep circadian rhythm. It's also used in insomnia to verify that people are going to bed regularly and how long their sleep can be, even though this is not ideal because of what we talked about before, where people sometimes lay absolutely still. But the more typical things is the polysomnography from type 1 down to type 4, the simplified measurements. So this is what we're going to focus on in this second part. There are huge technological advances that have happened in this field. This is a picture from around 1990 when people were going into the sleep laboratory, sleeping there overnight, and all of these devices stacked there on the wall are for one sleep study. And you can see that there is paper there at the bottom. So if you remember how I showed you the different sleep stages, how it looks, and there we're actually looking at 30 seconds at a time. And the reason we chose 30 seconds at this time, or I didn't, but the field did, was because it fit well on one piece of paper. So after every night, for each patient, after one night of a sleep study, there was so much paper. It was like the phone book of old days in paper from one night. And then the people reading the studies or scoring the studies, they had to flip through all of these pages. And if you think now, this is an example of a self-applied sleep device where you can just give it to patients. They have a video that they watch, and they put this on themselves at home and return it the next day. So you can think that there's amazing changes, of course, in the last 30 years in this. And if we start with the so-called type 3 sleep study, this is the typical home sleep apnea testing, or HSAT study, which is done then without EEG. Here's an example of this from one of the manufacturers. So what you have in these studies is you measure the nasal breathing with a cannula that you can see here in the nose of the patient. We measure respiratory movements with these two white belts. One is on the thorax and the other one is on the abdomen. And here you want to measure that the breathing movements are regular and that you can measure it in the nose. And when if people stop breathing, like in sleep apnea, these are very important sensors for that, as you can imagine. We measure the pulse. This is on the finger, this gray bulk there on the finger. We measure movements. This is done on the device itself, on the middle of the chest. So you have movements and position. It's very important, for example, for sleep apnea, to know if the person is lying supine or non-supine, that is on their back or not, because the sleep apnea is typically worse when you're lying on your back, or it can be worse at least. In some cases, we can measure sound and can listen to sound, snoring, if people are talking in their sleep, etc. And we also have oxygen saturation. Sorry, that was removed from the slide. So the measurement on the finger not only measures the pulse, but also the blood oxygen level. So what happens is that you have infrared light that goes through the finger and is measuring the color of the blood. So basically, there's a change in the color of the blood depending on how well saturated it is. So this type of sleep study is really done to see if someone has obstructive sleep apnea. You cannot measure insomnia with this, as you can imagine. You cannot measure narcolepsy, REM sleep behavior. This is really only for sleep-related breathing disorder, and is typically the one used for sleep apnea. In some cases, there is also a sensor that goes over the mouth, a thermistor that measures then the mouth breathing. This sensor is not perfect. It's really like an on-off sensor because it measures the heat of the signal, while the cannula is more quantitative. So in some devices like this one, you have the nasal breathing, and if the person opens the mouth and is breathing through the mouth, you will see this from the difference between the nasal cannula flow and the breathing movements. I've mentioned obstructive sleep apnea a couple of times, and this will be talked about specifically in its own section, but just very briefly, normal breathing, you can see the blue, the air is going very smoothly, it's moving freely in and out, while in OSA, or obstructive sleep apnea, there is something that is closing the airway, and this is happening regularly throughout the night, that people stop breathing for 10 seconds or longer, and you actually need an arousal to be able to wake up enough to breathe again. And then it's a vicious cycle of you falling more deeply asleep, the airway closing, getting an arousal, having a lot of sleep fragmentation, and then going back into sleep. So you end up with very poor sleep, and this breathing stops throughout the whole night. If we then go to the gold standard, the polysomnography, this is actually my dad. He allowed me to take this photo of him some 20 years ago when I was starting in sleep research. And you can see he is hooked up to a lot of different wires and things for his study. I actually I left him at the hospital and went home to sleep. I don't know if he's still forgiven me, but he did end up sleeping for most of the night. But you can imagine this is not going to be your typical sleep when you have this much stuff on. This is the way the sensors are still the same as they were 20 years ago that we do now, but there are devices that are starting to be smaller and more convenient for the patient. I'll show you that in a bit. But in this case, we are measuring the brain waves, the eye movements, and the muscle tone in the chin. And again, these three are for the sleep stages. If they are not included, you can't really measure sleep stages if you don't have these. We have then the EMG, or the muscle tone on the legs, for the periodic leg movements. We measure the EKG, or the activity of the heart. We measure nasal breathing, in some cases mouth breathing, the respiratory movements, pulse, movements, body position, sound, and oxygen, which fell out of this one as well. So you can see the last 6 of these, or 7 with the oxygen, they are also in the type 3 study. So the main difference for a polysomnography and the polygraphy, as the type 3 study is sometimes called, is the lack of the ability to measure sleep stages. In some cases in the type 3 studies, you start having a couple of electrodes on the head to get an estimation of the sleep stages. This type of study can either be done in the laboratory, and then it's called type 1, typically then with a video as well, or at home for type 2. And sometimes you do need video, especially for movement disorders and for REM sleep behaviors, etc. Here is an example of a more modern version of this type of device. You would need to put some Band-Aid on to make sure everything sticks, but you can see that it is getting less cumbersome for the patient, even though it is still a lot of electrodes and stuff that you have to sleep with. We talked about it before, that we look at 30 seconds at a time, and this is because it used to fit well on a piece of paper. So here is an example of a deep sleep epoch, as we call it, 30 seconds of deep sleep. We look at 30 seconds and decide which sleep stage it is. First, at the top you have the eye movements, then you have the EMG, and the last 6 represent the EEG, or brain waves, and these are always more strongly reflected in the frontal than in the central, and finally in the occipital. So you can see the top one of the 6 lines, the first 2, there's a bigger amplitude there. And what happens is that you have a sleep expert, either a sleep technologist or a sleep specialist, who is then reviewing all of these epochs for the whole night. So if you have an 8-hour sleep study, you have 960 of these epochs, for which we need to give a different sleep stage. Then we have to score it for arousals, and we have to look at the other traces for breathing events, for if there are any cardiac events, and the periodic leg events. So we will go into this more in the practical sessions, but I just wanted to give you a bit of a flavor for this. And this actually, on average, takes, if you do all of the scoring, according to current guidelines, it takes about 2 hours, even more, can take 3 hours for a difficult recording, just to go through one study. We do have automatic analysis, but typically we then review it manually. So there's a sleep expert that looks at all of the different scorings and all of the different events that are scored. And we'll talk about this more in the sleep revolution talks. So we are really looking now into how we can move from the paper. We're still working clinically as if we were still on paper to the fourth industrial revolution and the fifth and the sixth, so that we can use the technology to our advantage and make it quicker to work with these recordings, and quicker and better. And we'll talk about that more in our discussions. Type 1 PSG, or polysomnography, it's typically called PSG, is then the in-laboratory attended sleep study for one night. There has to be someone staying awake watching the signals. So you're basically sleep depriving the staff to measure the sleep of the patients. We call it the gold standard, and it is because of the fact that you can assure more the quality of the signals and that you have so many different signals. But there are disadvantages, both that there is limited accessibility and long waiting lists. Many of my colleagues after COVID now have up to 2 years waiting list to get a sleep study. And this is, of course, very long if a person has a disorder. It is quite time consuming and expensive. There's expert staff that places the electrodes, stays awake for you the whole night, and then there's very long scoring. And there's also the potential first night effect, because usually people only get one night of study. So sometimes, for example, for movement disorders, one night may not be enough, and you may need to do night 2 or even night 3. We don't address night-to-night variability here. For example, if you're looking at sleep apnea, it can be variable between nights, how severe it is. And if you just get one night, you only get a glimpse. It could be more beneficial to have, for example, 2 or 3 nights. Finally, if we go briefly into the multiple sleep latency test, or MSLT, and the multiple maintenance of wakefulness test, or MWT. So the first one, the MSLT, is it measures how long it takes a person to fall asleep under something we call optimal conditions. But the optimal conditions is then in the laboratory, in bed, turn off the lights, but with all of these measurements on. So basically you sleep there for the night, do a PSG, and then you continue throughout the day with all of the same measurements. So it's 5 naps that you take, and you have 20 minutes to fall asleep, and you're told you should try to fall asleep, or you should relax and try to sleep. And this is done every 2 hours during the daytime for 5 periods. And for example, in narcolepsy, people have a sleep latency of less than 8 minutes on average from the 5 different nap opportunities, and 2 sleep onset REMs. If you remember from the hypnogram, you're not supposed to go into REM sleep until after 90 minutes approximately. So you go through a whole sleep cycle of stage 1, 2, 3, and then you get a little bit of REM. And it's not, in healthy people, you do not fall asleep directly into REM sleep. But this is something you can see with narcolepsy. So if a person has an average sleep onset latency of less than 8 minutes, and at least twice out of the 5 times they get the nap opportunities, that they go directly into REM, this is a diagnostic criteria for narcolepsy. And you can see here in the picture that the narcolepsy patients are the ones that were the quickest to fall asleep on average, or their mean sleep latency, while if you look at the people with hypersomnia, idiopathic hypersomnia, they are also with a reduction, but it's a little bit more, longer that it takes them. Same for the obstructive sleep apnea. And then if you look at normals if they do 4 naps or 5 naps, you can see it takes them a longer time to fall asleep. The other test is the maintenance of wakefulness test, or MWT. This is not as widely used as the MSLT, and it's not used in any clinical diagnosis, as I understand it at the moment. But this is an objective measure of the voluntary ability to stay awake for a defined time under conditions that favor falling asleep. So you're either sitting up half upright in bed or in a cozy chair. And these are done, there are 4 trials that are done every 2 hours, again, after sleeping the night with PSG, and you leave the equipment on, especially for the sleep stages, and this is done for 40 minutes at a time. So this is mostly done for safety reasons. You have professional drivers, pilots that may have excessive daytime sleepiness, and this is then to test if they can continue this work. and they really have to try then to stay awake. There are no standardized cutoff values at the moment. It has not been determined yet, but for normal participants, the mean latency for falling asleep is about 30 minutes plus minus 11. So if someone cannot stay awake in this test and is falling asleep very quickly, this may mean that they need some treatment for their sleepiness, and then they are tested again to see if they can continue, for example, to drive. If you want to read more about the MSLT and the MWT, this is an updated recommended protocol for this from the American Academy of Sleep Medicine, the AASM, which is also the ones that have the manual for sleep staging that we will go into later in the course. So to end this part, we have an assignment. For yourself, consider the pros and cons of the different sleep measurements. Do you believe that any one type of measurement is enough to measure sleep? Or are you only able to capture a dimension of sleep if you measure one? And what are you missing out with any of these different types? So thank you very much for your attention, and I look forward to discussing this with you more.